Hi, everyone. My name's Dr. Don Buford. I'm an orthopedic surgeon, still based in Dallas, Texas, if you've seen some of my other video presentations at this meeting. The title of this one is Evaluating Recent PRP Publications, Journal Club 101. My disclosures haven't changed. So the first article I'd like to discuss was published in JAMA back on October 26th, 2021. The title was something that caught all of our eye. Anyone in the business was interested in looking at this article because the title is Effect of Platelet-Rich Plasma Injections versus Placebo on Ankle Symptoms and Function in Patients with Ankle Osteoarthritis. And then the subheading is a randomized controlled trial. So great, here's another article that I'm anticipating is going to show that PRP is effective in patients with ankle arthritis. And so we look at the abstract and everything checks out pretty good. We can see that their objective is to determine the effect of PRP injections on symptoms and function in ankles with ankle OA. The design, setting, and participants seem to be spot on. This is a multi-center trial with block randomization. It's double-blinded, placebo-controlled. It's checking all the good boxes, right? And we look at the intervention. We see that patients are randomly assigned to receive 2 ultrasound-guided intra-articular injections. 48 patients in the PRP group, 52 patients in the normal saline group. So up to this point, this looks great. So now I'm really curious to see the outcome. They have typical outcome scoring parameters. The results were quite disappointing, however. When you look at their conclusions, they conclude that among patients with ankle osteoarthritis, intra-articular PRP injections compared with placebo injections do not significantly improve ankle symptoms and function over 6 months. And so that was a real head scratcher at that point for me because I do PRP for patients with ankle osteoarthritis and our results are generally good. And their final conclusion was even broader, that PRP does not work for ankle arthritis. The findings of their study do not support the use of PRP injections. And so for us that use PRP for this condition, a bunch of questions immediately pop into mind. What in the heck happened? Did they lose patients to follow-up? Did they not do ultrasound guidance? Was there a problem making the PRP? And so we go back into the article and they didn't really lose any patients to follow-up. These are ultrasound guided injections. But then we get to the PRP. And what we see in the PRP is in their procedure, they note that they use a commercially available system called the Arthrex double spin PRP system, which is the Arthrex, what used to be called the Arthrex ACP system. They collected 15 cc's of autologous blood, and that's what they used to make PRP. So article review point number 1, this was low dose PRP. A lot of us that use PRP for this condition are drawing 60 cc's or at least 30 cc's and concentrating back down to the 2 or 3 cc injection. So just drawing 15 cc's is a low dose if we're still comparing apples to apples. Review point number 2 is that they did not quantify the PRP, so we don't even really know that it was PRP. They drew 15 cc's of blood, they injected 2 cc's, and again, using this Arthrex system, we know from other publications that that system concentrates only 1.2 to 1.5x over whole blood. So I would go back and look at their original conclusion, which was that PRP does not work for ankle arthritis. If I were editing this in an ideal world, I would say, look, we have to change this. It's too broad. What you injected was not necessarily PRP because we have no quantification to prove that. So the revised conclusion at best would be very low platelet dose, leukocyte poor, autologous conditioned plasma did not work for ankle arthritis. And if I'm being real, my real conclusion would be that very low dose leukocyte poor PRP does not work for ankle arthritis. And I can't even really know what I did because I forgot to get a CBC and PRP hematology. For some reason, JAMA's been on a roll the last 4 to 6 months, right? Because this is another article published in JAMA. I don't know why they hate regenerative medicine, but this is another article that caught all of our attention because of the title. So back in November, they published this paper with the title of The Effect of Intra-Articular Platelet-Rich Plasma versus Placebo Injection on pain and medial tibial cartilage volume in patients with knee osteoarthritis, the RESTORE randomized clinical trial. So right out of the gate, we're checking a bunch of boxes, right? We've got a randomized clinical trial. We're going to be looking for disease modifying outcomes with cartilage volume being assessed. Very excited to read this article and to hear their conclusions. When you look at the abstract, we can see that the design was well done. It's a randomized 2-group placebo-controlled blinded clinical trial. You really can't design it any better than this. This was a fantastic design. The authors are to be commended for that. Their particular protocol involved 3 intra-articular injections at weekly intervals. And again, can't argue with that. This could shed some light on whether we should be doing multiple weekly injections versus a single high-dose injection. Their primary outcome measures were appropriate, and they followed these patients through 1 year. And so they looked at average knee pain scores. They did MRI scans. This was an expensive, well-done, randomized clinical trial. They had 288 patients, so it seems to have adequate power. And we look at their conclusions, and we're disappointed. What we see is their conclusion that among patients with symptomatic, mild to moderate radiographic knee OA, intra-articular injection of PRP compared with saline did not result in a significant difference in symptoms, meaning it didn't change anyone's pain, and it didn't have any effect on the tibial cartilage at 1 year. And then their final conclusion, these findings do not support the use of PRP in the management of knee OA. So in this article, JAMA's single-handedly trying to take down over 30 other level 1 trials that show that osteoarthritis is treated quite well with PRP. And so again, this becomes a real head scratcher for those of us that have been using PRP for a decade plus in patients with knee OA. And we know that it works, and we have data to show that it works. And so it's always curious when we see something published that contradicts what we know to be true. And we have the same questions that we had with the first article. Again, this was a brilliantly designed and executed study. They didn't lose patients to follow-up. I actually didn't see where they used ultrasound guidance, but I don't think that would lead ultimately to this conclusion in the first place. But then we get to the problem making PRP. So we have to dig into the article and assess what kind of PRP did they use and how did they quantify it. And so when we do that for this paper, we see that they used a system from a company called regenerative. And this is basically a test tube based system. It does yield a platelet product that is leukocyte poor. Now, in the author's own words, in their documentation, they say that their regenerative system yields a platelet concentration factor of 1.6 to 5x with 80% platelet recovery. So number one for me is that this is still low dose PRP because they only drew 30 cc's of blood, I'm sorry. And most of us for a single knee are still drawing 60 cc's of blood just based on the progression in our knowledge. Review point number 2 is that the PRP that was used in this paper actually was quantified. So unlike the previous paper where they didn't quantify it at all to prove that it was PRP, these authors even took the extra step of getting a CBC and getting a hematology on their PRP product. And so now we actually have some objective data to say, yeah, this was PRP and here's what the dose was. But wait, there's more. Remember what they said. They said that this protocol yields a platelet concentration of 1.6 to 5x using this regenerative system. When you dive into their supplemental data, this isn't in the main body of the text. I think it should be. It should probably be in the abstract. But when you dive into their supplemental text, what you see over here on the right is that their average platelet count was 270 for their patients in this study. And guess what the average PRP platelet count was? 325. Anybody have a problem with that? 325 is still well within the normal human range. So on any given day, they could have just done this study without going through the exercise of centrifuging anything, because they did not concentrate this enough to get above the normal human range of a platelet count. And when you do the platelet concentration math, 325 over 270, that's just 1.2x. That's not very much. That's even below the documentation supplied by Regen Labs and quoted by these authors that the Regen Lab system concentrates 1.6 to 5 times. The numbers that these authors got of 1.2x concentration exactly match what other researchers have gotten using this system. So I think their result is accurate. I think these researchers were very honest and very transparent. And as a result, I trust their result. I trust their data. What I don't trust is their conclusion. And so their conclusion is that PRP does not work for knee arthritis to decrease pain or increase volume. Again, if I were, the editors are, the revised conclusion at best, giving them a couple, passes, would be that very low dose leukocyte poor PRP did not increase did not decrease knee arthritis pain or improve cartilage volume. My real conclusion that I would tell all of you in the audience is that this paper is conclusive evidence that low dose PRP for knee arthritis does not work. And I don't think there's a need to repeat this study ever. I think we can just move past this, and now we can define the floor. This is clearly below the floor because it doesn't work at all. So I would propose for all of us that are still using PRP for knee arthritis and seeing good clinical results, that we define the floor as being 30 to 60 cc's and a certain level of concentration and a certain dosage. And that's what these studies really have taught us. So unfortunately, I think they broadened the conclusion so much that it became more of a shock piece. It became more of a shock article, like, wow, PRP doesn't work. And a lot of people that don't use these regenerative medicine orthobiologics will use papers like these as proof to say this doesn't work and here's the evidence. But you have to really look at the data to be a complete clinician in this field. So I appreciate your attention, and hopefully this will give you some take-home pearls when you're looking at some literature in the future.